Well, welcome to the Aging Boomers. I'm your host, Frank Sampson. Of course, on our show, we discuss so many of the issues facing boomers, their parents, and of course, an aging population, which I fit right into. So I want to remind everybody that today's show is sponsored by Senior Care Authority, a senior placement and elder care consulting organization that has a national network of professionally trained and experienced local advisors to assist families. They'll work with you in determining the right path for you or your loved one and discuss various long-term care options, whether it's in-home care, assisted living, memory care, or even nursing, or if you just need an advocate to get advice from a Senior Care Authority advisor for your loved one. You can get a call for a free 30-minute consultation by contacting Senior Care Authority at 888-809-1231, or you could go directly to the website at www.seniorcareauthority.com. I also just want to, again, thank everybody for all their support. Our listeners are growing and growing each and every day, and it's all because of you, because you're getting the word out. And many of you, of course, go on to iTunes or iHeartRadio or Spreaker or Stitcher, but I'd have to say probably our greatest growth is just those that are just downloading our free app, which you can get on your iPhone or on your Android phone. Just type in the Aging Boomers and download the app, and you can keep up to date on all the all the interviews that we do with some great people. Also, you could do the same thing on iTunes as well. So, again, thank you for all of that. And speaking about wonderful guests, we're honored today to have two of them. All right, so I'm going to introduce both. Dr. Emilia Ripoll, who's an MD, has practiced urology and urologic oncology in the Denver metro area for more than 25 years. As an American Urological Association Foundation scholar, Dr. Ripoll researched genetic predisposition and the role of proto-oncogenes, I messed it up, doctor, I'm sorry, in the development of prostate cancer. We also have with us Mark Saunders, who is a writer, editor, publisher, public speaker, and 11-year prostate cancer survivor. As an active surveillance patient, instead of receiving traditional treatments like surgery or radiation, Mark dramatically overhauled his lifestyle, and the cancer became undetectable and hasn't returned since. So congratulations on that, Mark. So both Dr. Ripoll and Mark have co-authored two books. One's called Prostate Cancer, A New Approach to Treatment and Healing. And the other one is called Do You Have Prostate Cancer? A Compact Guide to Diagnosis and Health. So Emilia, and if I may call you Emilia, and Mark, welcome to the Aging Boomers. Thanks so much for joining us.
Thank you for the invite. We're really excited to be here with you today.
Yeah, thanks, Frank. It's great. It's a pleasure.
Well, thanks for taking the time. So, talking about prostate cancer, I think that's our main subject matter here. Just this past week, there's been just so much news on, about studies where men have been advised first of all, not to have certain blood tests over a certain age because these tests could be inaccurate. And then recently there was information that said, yes, if you're over a certain age, you should have the test. So I'm going to ask you, which is it? What should people do?
Well, Frank, to be honest with you, the United States Preventive Services Task Force reversed course, essentially. They came out with a ruling about 5 years ago that said men should not have a PSA test because they were worried about what they called harms, potential harms from a prostate biopsy and potential harms from treatment. And now they've changed directions and said, well, men should talk to their doctors. So they gave a specific slice of men between 59 and 75 should talk to their doctors. And we agree with that. PSA tests are not perfect tests. They tell you that if you have an elevated PSA test, it says that the tide is rising. Now, why the tide is rising, we don't know. It could be an enlarged prostate, it could be an infection, it could be any number of things, and it could be prostate cancer. But you won't know just from a PSA test. But fortunately, there are lots of other great tests out there, and Dr. Ripoll can tell you more about those. But these tests will help men figure out, well, do you need a prostate biopsy? And if you have a prostate biopsy, then you can figure out where to go from there. But PSA tests are great. They're a good first step.
Yeah, I think where this whole thing started was years ago, in that I think that the PSA test was overused and possibly misinterpreted by a lot of physicians, and therefore the number of biopsies went up dramatically, and so did the treatments for prostate cancer, even in people who were known to have the low-risk type of prostate cancer. So I think the reaction of the whole establishment was to say, okay, in order to avoid that, let's not do the PSA, which is the proverbial hiding your head in the sand, like the little birds that do that. But the honest truth is that when we had done PSAs on a regular basis, we really decreased the number of people that died from prostate cancer. We really started detecting men earlier on in their process, and it made a big difference. And when we stopped doing that, what we've noticed clinically is we noticed that we're finding people at a later stage. And so I think that's one of the reasons why now, they're backtracking and saying, okay, maybe we should be doing this. We just need to educate both the patients and the physicians not to either overtreat or overdiagnose people. So I think we're moving back to a more reasonable stand, and I think that if we educate the patients into regards of their, what these numbers mean, and also the realization, fortunately, that over the past 5 years, we have improved in the type of testing that is out there that can really distinguish between a benign inflammation or infection of the prostate or just enlargement versus people that truly do have a significant prostate cancer. And even among the patients that have prostate cancer, we can start detecting now a difference between what we call a sheep and a wolf. So a lot of the testing nowadays is trying to find the wolves in sheep's clothing. And I think that's going to be more refined. It's going to avoid over-treating and under-treating. So it's going to take us to an age of being more appropriate in diagnosis and treatment. So I'm actually really excited about some of these newer methods that are out there available for every American nowadays. So
bottom line, if you're in that age group, all right, what you're saying is going in for that PSA test, which, so people know, it's just basically it's a blood test, right? It's a blood test.
Exactly.
So people that are going, well, wait a second, why wouldn't I just go get a blood test? What I learned, recently with my doctor, ironically, is that's not the issue. The issue is that if the PSA test comes back, I don't know what the right term is, elevated or whatever the term is, then you may have to go in for additional tests, which isn't necessarily the most comfortable thing to do. So that's more the issue, correct?
Yeah, Frank, let me talk to it directly because I can talk about my own personal experience. I've had 3 prostate biopsies, and the last one gave me sepsis, and I was 6 to 12 hours away from dying.
Wow.
And so I have personally experienced the quote-unquote harms that the government, task force was trying to reduce by saying don't get a PSA test. But if I never had a PSA test, I would have never known that I had low risk, low volume, early detected prostate cancer, and I would have not known to change directions in my life. I would have not known to become an active surveillance patient. I wouldn't have changed my diet and my lifestyle radically, and I wouldn't be where I am today. So it's a balancing act, but as Dr. Ripoll said, there's a lot of other tests from a PSA test before a prostate biopsy that can help identify the likelihood of cancer, and is that cancer aggressive? And that's the new frontier, so to speak, and that's where I think. Go ahead.
No, I was going to say, I agree with everything Mark said. What we're trying to do with the newer testing is actually avoid unnecessary biopsies, which I think is what you were referring to. Just because you have an abnormal PSA doesn't mean you're going to end up having a biopsy. The contrary. There's things that you can look at, like family history. You can look at the age of the patient, whether the rectal exam is normal or not, what racial group you belong to. You can look at what your PSA has been over time, which we call PSA velocity. You can look at other parameters like free and total PSA and PSA density, etc. There's a lot that you can know by history that can really help you refine. So what we're saying is that by doing that, which is a lot of what we talk about in the book, you can actually minimize the number of biopsies, but still detect those poor patients that are at a higher risk of dying of their prostate cancer. I mean, whether we like it or not, prostate cancer is the number 2 cause of death of cancers in men in the United States. So detecting, being able to find those that's why I keep using the analogy of the wolf, finding those cancers that truly could end up developing into a more serious cancer is super important, because you and I know that the majority of prostate cancers are going to be clinically insignificant, but not all of them. So the true importance of this whole basis is, how do we distinguish between one and the other before we even go into a biopsy?
Right.
Does that make any sense?
Yeah, absolutely. Sense? I mean, I guess, Dr.
So we have tools now.
Yeah. So, just based on the title of your book, I haven't read it yet, and I'm going to, all right? But just based on the title of one of your books, Prostate Cancer, A New Approach to Treatment and Healing. So, I mean, obviously, I don't expect you to go through everything you wrote in the book, but what's the main
How long do you have, Frank?
Yeah, so what's the main difference between what your approach is to treating prostate cancer and maybe what has been the standard medical approach? Or did you already answer that and I kind of missed it?
No, I think that, thank you for opening it up that way. So basically, by nature, I'm a minimalist. Meaning that I do believe that in the past we overtreated via different, radical prostatectomies, radiation, people in reality who didn't need any of that. There's a lot of prostate cancers that are going to be what we call clinically insignificant or very low grade, and that I would say could be up to 80% of the prostate cancers, which all they need in reality, it's a change in lifestyle, a change in, looking at other things in their, do they have heavy metal toxicity? Do they have, poor diet, immune system? Is it working properly? Is it not, etc.? Are these people, oxygenating? Are they by exercising on a regular basis, etc.? So what we're trying to do, which I think is a little different, is how to minimize treatments that not need to be there. So we really educate people on, are you a perfect candidate for what we call active surveillance? And what's active surveillance? Just an opportunity for people to get healthier, to look at their life and say, am I overworking? Am I doing what I need to be doing, etc. And also, going more into the newer concepts of, what we call focal treatments. The same as with breast cancer, where we used to, if a poor woman ended up with breast cancer, we used to take the whole breast out. Now we're doing lumpectomies. Those concepts are now bleaching into prostate, and there's a lot of people that may qualify for a focal treatment where instead of treating the entire prostate, they can just go ahead and freeze a little area of the prostate. So more of a move towards active surveillance, opportunities to change your lifestyle by improving your health, and also, is this appropriate to just do focal treatments rather than an entire treatment for the entire gland? And you may say, well, why would that be important? Because the side effects are significantly reduced. You don't have to worry about leakage of urine. You don't have to worry about sexual dysfunction if you go into active surveillance or if you do focal treatments. Now, I wish I could tell you that everybody's going to be a candidate for that. No. There is the rare patient, or the 20% of patient, or 25, who are going to need a more definitive treatment. And so that's what we're here for, is trying to educate and help people realize where they're at. And I know Mark will tell you more about how our book is designed in order to help people do that, how to empower them.
Great.
Thank you, Emilia.
Yeah, Mark.
Go ahead, Frank.
Yes, I wanted to ask you. So, I mean, you obviously you made some lifestyle changes yourself, okay, after you were diagnosed, and so when you hear about somebody, another man that you talk with that has been diagnosed with prostate cancer, how do you then determine to say, hey, here are some of the lifestyle changes I made and you should do the same thing? I mean, could that work for most or some, or how do you determine that?
Well, it's far be it for me to tell anybody what to do. That's number one. And number two is that the kind of cancer I have may not be the kind of cancer that this other man has. So it's like there's a big spectrum of quote-unquote prostate cancer, and we go into that in detail in the introduction of both books, and in the last chapter, chapter 10 of prostate cancer, we go into great length to discussing all these different lifestyle changes, and it all depends on the individual. In some respects, this is trying to find the right shoe for your foot. What condition do you have? How old are you? What's your ethnicity? What's your family history? Is your general health good? If so, where can we tweak? And it's different for everybody. So you can't do a one-size-fits-all because it just doesn't work. And I think what Dr. Ripoll was talking about earlier was like, well, it used to be that people got prostate cancer and the only choice was, well, they got a radical prostatectomy. And that's a little bit like Abraham Maslow's, if the only tool you have is a hammer, then everything looks like a nail. And now it's very different. There are lots of very focused, minimally invasive treatments that Dr. Ripoll was talking about that are great. As far as lifestyle goes, the big three are diet, stress, exercise, and that's what I would say to focus on for anybody, because we all have control of what we put in our mouth. We all can shave off 20 minutes a day to go for a walk, and we all can learn some little things about how to breathe better. Like I just took a belly breath. It's learning to do those kinds of things every day, all day long, getting out of your chair, walking around, going to the water cooler, whatever. It's just little things like that can have dramatic effects.
Yeah. I want you both to talk a little bit more about your books and kind of who it's geared for, etc. But I did see something that Mark, that you describe your books as picture books for grown-ups. Tell us a little bit more about that.
Well, it was Emilia's concept that we've been writing books the same way since Gutenberg first chunked out the first Bible. It's basically a lot of words with maybe a picture thrown in at the beginning and the end. We decided to make this intuitive, easy to understand, and you can get 80% of what's in the book by looking at the pictures and reading the captions. We wanted to use the text to support that information. There's lots of great information in the text, don't get me wrong, and we created sections in the book to make it so simple for people. Like there's a toolbox section. Basically, it's a place where you can plug in your own numbers, you can use your information, you can answer questions that helps refine the process for you, because specifically for the prostate cancer book, we want people to make the right choice. That's the only reason that we wrote this book, is help people make the right treatment choice for them. Because there's a lot of different treatments out there, and you got to figure out what category do you fall in, and B, within that category, what treatment options would be best for you. We're not biased. We don't have a horse in the race about which ones you use, but we want you to get better.
Right.
I mean, from a personal perspective, 11 years ago, these are the books I went looking for and couldn't find. They didn't exist. And so with Emilia's expertise and my writing skills, we came together and we put this book together so anybody can read it. I like to say, if you can read the Sunday sports section, you can read and understand these books.
So would you say that, both of them, based on the title alone, seem to be geared, for someone who has already been diagnosed with prostate cancer, but do you think it could also be helpful to someone maybe in that age bracket,
Right.
but hasn't been diagnosed. It could be almost helpful from a preventative standpoint. Is that possible?
The book you're describing right there is Do You Have Prostate Cancer? And that's the blue book. And it's designed for men who have perhaps had an unusual PSA test. Maybe the levels came back a little high. Maybe the digital rectal exam was slightly unusual. And then, okay, now what do you do? And so this book guides people through the process of figuring out what's making their PSA number high or giving them an enlarged prostate or something like that. And it contains step-by-step information that guides them through the whole process of what it would be like to see your doctor 3 or 4 times. And it gives you lots of information to ask questions, because it's our confirmed belief that educated or informed patients make better healthcare choices. It'd just be like, you could say the same thing about car shopping or, buying vegetables. If you know what you're looking for and if you know what questions to ask, you're going to get a better product. And we want people to get the best possible diagnosis and results and pathway going forward that they possibly can.
Yeah. So I guess what could be helpful also, and I guess, Dr. Ripoll, either one of you could certainly answer this, but when someone is sitting with their doctor, all right, and what are the key question or questions that you could that you recommend to a man in that kind of that age group, whether they have prostate cancer or not? Maybe they need 2 answers to this, but the types of questions they should be sure to ask their doctor.
Yes, I'm glad you asked that, because that was one of the things, whether we like it or not, no matter how strong we are, no matter how together we are, when the word of cancer pops up into the picture, whether it's, whether we have it or we may have it because we have a genetic setup where we go, oh my goodness, my brother had it, my mother had breast cancer, it's a frightening word. And the minute you hear that word, it's like we go back to hearing only 10 to 20% of what anybody is talking to us about. So what we did in the book to try to help with this scenario was, in the toolbox, we have specific, pages where we go, if you go see a family doctor, this is what you ask, and there's like 20 questions. If you go talk to an oncologist, this is what you would ask. And we try to simplify it that way. We try to make it so, you take some of that anxiety and in that situation where you get home and you go, oh my, I wish I would have asked this, that, and the other. And so we try to minimize that by writing these long lists, which I think are going to be really, really important. I think what was important to me, and I know that my partner here would echo, is that I was so tired of the kind of medicine that we practice that is cookie cutter. You go to somewhere and everybody gets the same treatment, whether you like it or not, regardless of how, you feel about it. And so what we were trying to do is, how do we turn that cookie cutter medicine into a personalized kind of medicine, where we really try to find what is important for that patient in the context of their family, their work, and to themselves. What can they live with or not? Some people may say, well, impotence is not so bad for me, but oh my, if I end up leaking urine, that would be very significant. So we try to translate that into what treatments would be appropriate for that. And so we try to minimize some of that difficulty in knowing, what pros and cons are for each decision. I think that one of the fortes of the books is to do that for people. And also to help them find out what's important to them. A lot of the questionnaires we have in the back and the toolbox is helping them find, what could I live with or not? What's important to me and my family? So anyway, to make a long story short, the way that we divided the book, and with a section of the toolbox is designed to inform people and to prevent them from going anywhere and undergoing a treatment that they're not comfortable with out of fear or out of lack of information. And so how do we change that everybody gets the same thing to creating that mentality of the patient to say, I am the consumer, I am important, and sure, you have a lot of years of experience, but this is what's important to me. Help me figure out how to get there.
And if I could add, just from a patient's perspective, to my brothers out there and my sisters who are taking care of my brothers, basically you get to choose. It's your call, it's your body, it's your life, it's your choice. And yes, you may be instructed by your doctor to have a particular procedure, and if that feels like the right thing, great. But you should never be strong-armed into anything, or just because this is what a particular doctor does, that you should have that kind of treatment. I really encourage everybody who has prostate issues to get second, third, fourth opinions, because you will find different doctors who treat things differently, who have a different approach to things, and that's what, assuming that your health insurance will cover it, assuming you have the finances to do it, additional opinions are very helpful and very eye-opening. Of course I want you to buy our books, but the books are really to guide you in your process, and that's going to involve a doctor.
I'm curious, Mark, were you symptomatic? Is that why you went in, or did you just go in for a regular physical and the test was given to you and this was discovered?
It's interesting. I was symptomatic, but it wasn't due to prostate stuff, or the prostate problems were related to it, but I think they call it comorbidity. It was, there are two different problems going on with the same thing. I had low testosterone because I was eating a lot of soy and eating a vegetarian diet, and I was having some erectile problems, and I was having this sort of puffy feeling in my prostate. And I didn't know how to describe it. And then I had a higher PSA test, and then it went from there. Gotcha. But I wasn't having I did get up in the evening to go to the bathroom, like in the middle of the night sometimes, and that was becoming more common. So there were some of those little telltale signs, but I wasn't having trouble urinating or anything like that.
Yeah. Okay.
I
was curious. I was just curious because I wanted to make sure people, which you kind of answered it, that those that are listening to this to understand what are the signs. What are the
Frank,
signs?
to be honest, sorry, I didn't mean to step on you there.
No, go ahead.
The number one thing that I was concerned about at the time, I was tired all the time. I was just worn out. I couldn't figure out what was going on. And it had more to do with my diet and my stress level and lifestyle changes than it did anything else. And ironically, the thing that changed the sense of lethargy was also the thing that healed my cancer, which is also the thing that made me healthier and happier and a better person.
Great. So we only have another moment or so, but I'd love you to tell people a little bit more about your book, how they can get it, and it's commercial time. Go to it.
Commercial time. Amazon.com. Hello. How are you? Right now you can get the book on Amazon.com. Today we're going to sign a national distribution letter for a book chain distributor who's going to get the books out to all the bookstores in the world. But right now, Amazon is the best way to go. It's available both in print and in the Kindle format. So if you like reading electronic books, you can certainly get it that way.
Again, even though I mentioned the name of the book earlier, why don't you go ahead and mention the name again?
Okay, so we have two books. One is Prostate Cancer, A New Approach to Treatment and Healing. This is a book for the 180,000 men in the United States every year that get diagnosed with prostate cancer, or the nearly 3 million men who are living right now with prostate cancer. The other book, which is called Do You Have Prostate Cancer? A Compact Guide to Diagnosis and Health, is for the 50% of American men over the age of 50 who have prostate problems significant enough that they go to see their doctor about it. So if you're having prostate issues, you're getting up to pee 4 times in the middle of the night, you're having to pee all the time, something's going on, but you don't know what it is, maybe you're having erection problems, this is the book for them because it helps them figure out what they have and what they don't have, and it helps them have educated conversations with their doctor, which is really where it's at. Once you can have an educated conversation, then you have a better understanding of what's going on, what your options are. Does that help?
Perfect. Great job, both of you. Thank you so much, Dr. Emilia Ripoll.
Thank you.
And Mark Saunders. Thank you for joining us. And hey, my guess is there's going to be more books to come, I guess. So feel free to reach out. We'd love to have you on and keep us up to date on this very, very important issue. So thanks for joining us on the Aging Boomers. And I want to thank everybody out there for joining us. Just be safe, and we'll talk to you all soon.